Hello, hello, hello. Welcome back to another edition of Be Well Together. We are delighted that you are joining us here today. We have a very, very special speaker, something that's very close to all of our hearts. We're going to talk a lot about equality today. And who better to do so than like an ER doctor and an equality specialist, Dr. Uché Blackstock. So for those of you who do not know her, and full transparency, I've been reading up on her and I'm like completely impressed with this woman. A former associate professor in the Department of Emergency Medicine at NYU School of Medicine. She is also the founder and CEO of Advancing Health Equity, which partners with healthcare and related organizations to address the really critical factors that are contributing to health inequities. She is a leading voice in inequities and racism in healthcare, and just so much wow around this woman. I mean, she's got two, I think not one, I think, but 2 degrees from Harvard. So this is, button up, folks. We're going to have a really important and amazing conversation today as Dr. Blackstock is going to discuss medical equity and how specifically COVID-19 has been really disproportionately impacting communities of color. So what can we as allies do to help support them in this time of need? So welcome, Dr. Blackstock.
Thank you so much for having me.
We are delighted you are here.
Yeah. I'm excited to be here. I have a few slides, more than a few slides, just to help enhance my discussion with you all. And then I'm very happy to take questions towards the end. So I'm going to just share my screen now. So I'm excited to be here for Be Well Together. I'm just going to tell you a little bit about me, talk about some of the pre-existing racial health disparities that we've had in this country, talk a little bit about COVID, and then kind of what I've been doing, working on the front lines and how I've been helping, just helping other people, but also engaging in self-care in this really difficult time. So I always start out my stories with, this is my mom. She grew up in Brooklyn, New York, where I live now. She grew up very, very different upbringing than I did, in poverty, 6 siblings, single mother, but incredibly determined woman, loved science, and ended up being the first person in her college to go to college, first person in her family to go to college. She ended up at Brooklyn College and had a professor there who encouraged her to go to medical school. She applied to about 10 medical schools, got into all of them, and ended up attending Harvard Medical School. And so this is I have a twin sister who's also a physician. That's me on the left, that's her on the right, with our father. And so unfortunately, our mom is not there. And our mom is not there because she ended up being diagnosed with leukemia when we were in college, and we ended up losing her. But she was an incredible inspiration to us in terms of the work that we do as physicians. And we always felt an obligation to give back to our community no matter what we did with our training. I wrote this article in Chicago Tribune last year, and it really was in honor of my mother and her struggle, because what I really did appreciate was that as I got older, she had been through a lot, growing up in poverty, not having role models, not having the same opportunities as others. And so she had overcome a number of structural barriers to become a physician. And what is interesting is that, only 4% of physicians are Black. And our US population is 13%. And so, Black physicians are obviously underrepresented in healthcare. And what we do know is that workforce diversity is one of the solutions to ending healthcare disparities. And so I wrote this piece really about the importance of having representation of Black healthcare professionals, because that's one of the ways that we can address health disparities. And so what led to me leaving my academic career was I decided I really wanted to be a change agent. And so I started my company, Advancing Health Equity, to really work with healthcare organizations around health equity issues because of these disparities that we've been seeing. And we've really been seeing them for quite a while. What we do know is that there is a racial outcomes gap, and not just in healthcare. It's in basically sort of every aspect of our society: education, wealth, incarceration, life expectancy. So here are some statistics that I wanted to share with you all. So what we do know is, and this, we have the data for this, and despite advances in healthcare technology, we still have these persistent disparities. Black babies have the lowest birth weights and highest infant mortality. Black women have the highest mortality rates, and Black men have the shortest life expectancy. This was an article in New York Times Magazine in 2018. It's really a great read. If you have a chance, please read this. But it really talks about how these maternal mortality disparities have persisted. And there are a lot of different factors as to why, and we'll go into a little bit of those. And what's interesting is that these disparities really cross socioeconomic status. So even, I'm sure you've heard of Serena Williams and Beyonce. They have even had their own experiences as mothers where they felt like they were not being listened to. And so even Serena Williams talks about complaining of shortness of breath and chest pain after she had her child. And of course, she's someone who knows her body very well as a professional athlete. And it ended up she had a blood clot in her lungs. And so, as I mentioned, these disparities really persist across socioeconomic status. So even myself as a professional Black woman, I have the same rate of dying around giving birth as a white woman with an 8th grade education. And so obviously, these disparities are quite profound. And so the reason why we have them, and I know a lot of times we wonder why do we have these disparities? And they really boil down to what we call the social determinants of health. And those are housing, access to quality education, access to gainful employment with sick leave and benefits. And also, just to keep a note, individual behaviors are actually only a very small percentage of contribution to health outcomes or the health status of communities. So these social determinants of health are the areas that we need to address if we want to improve health disparities. And so one way of thinking about them are individual resources. So the education somebody has, the type of job, neighborhood resources. Do they have access to healthy foods? Is it safe for them outside so they can exercise outside? Are there green areas? Also, an issue that we know is related to asthma is environmental hazards in communities of color. And we know that's correlated to high asthma rates. And opportunity structures are also very important to think about. What is the availability of jobs and what is the quality of education in schools for community members? And so why do these inequities exist? There are different reasons, but really it's differences in the quality of care people receive within the healthcare system. And a lot of this, has been documented in the medical literature that, and we'll go into this, there are, bias on the part of clinicians, even though they are unaware of it, towards patients. There's differences in access to healthcare. Communities of color have lower rates of insurance, and differences in life opportunities, as I alluded to on the prior slides. And so I love this image. I don't know if any people have seen this before, but it talks about the difference between equality and equity. So we have 3 people, they're trying to watch a baseball game, and there's a fence there. And what that fence represents are structural barriers, right? But if you give everyone the same thing, so you each give them a box, even though they're different heights, the shortest person still can't see. So that's what equality is, giving everyone the same thing. But what equity is giving each person what they need in order to reach their highest potential. So if the shortest person needed 2 boxes, then they needed 2 boxes and they all can see the game. And on the far right is liberation, which is what happens when you don't have these structural barriers, that we don't have racism, we don't have sexism, and where everyone can have the same opportunity to live their life to the fullest. And so I just wanted to go over just some definitions. So health equity is the opportunity for everyone to attain their highest health potential. And health inequities are differences in health conditions due to societal or economic disadvantages that actually are man-made and can be preventable. Oh my goodness, sorry, my 3-year-old. Okay, so Mom was talking.
All
Okay.
good. All
Sorry
good.
about that.
All
Dada, can
good.
you close the door? Thank you. um, and so I wanted to share this pyramid with you all. You know, it shows that the largest impact on health outcomes are socioeconomic status. So poverty and inequality has the largest influence on someone's health versus the individual at the top of that pyramid, eating healthy, okay, taking your medications. That has the smallest impact on health outcomes. So if we're able to address socioeconomic factors like housing, job employment, poverty, inequality, we can actually improve communities' health status. So let's talk a little bit about COVID-19. This is a piece I wrote for Scientific American, and I actually wrote it in March. And in March, we didn't have any data, racial or ethnic demographic data on which communities were being most impacted by COVID-19. But I had predicted, based on what we knew about the pre-existing health disparities, that communities of color were going to be the heaviest impacted. And what we did see turned out to be true. So this is from a recent study that showed that counties with majority Black populations had disproportionately higher rates of deaths from COVID. Even on Navajo Nation has the highest per capita rates of coronavirus compared to any state. So that's really profound. And we're thinking about, you know, what are the issues? We know that there's a lack of running water on Navajo Nation. We know that there's a lot of crowding, which means that there are more people living in a house or an apartment than there are rooms. And so these all contribute to the disparities that we're seeing. And then even among our Latino population, we're also seeing profound health disparities across the country. And so where are we seeing these disparities? We're seeing them in who is being tested, we're seeing them in who's being infected, who's being hospitalized, and who's dying. And so there are a number of factors contributing to this. There's testing criteria and availability. And so one thing I noticed, I'm an urgent care physician, I noticed at the beginning of the pandemic that in the neighborhood that I was serving, which is mostly Black and brown people, that we didn't have testing. And if we did, they were limited to certain people who had either traveled to Italy or China or Iran, places where coronavirus was already endemic, or they had to know someone who had been tested. And so I fear now, in retrospect, that we may have missed many people because the folks in the community that I serve, they're mostly essential workers, they're service workers. They had not been traveling out of the country, but the criteria itself had some bias in it. And so we were not able to test them. We also know that communities of color carry a very high burden of chronic disease, diabetes, high blood pressure, asthma, obesity, and we're learning that all of those comorbidities are actually risk factors for developing serious complications of COVID-19. And then we also know that provider bias, we have a lot of literature that has shown that clinicians have an implicit preference for white patients over patients of color. And so this has also contributed, and there have been a number of stories that we've seen in the media about this, of people returning to the ER more than once, requesting tests, not receiving tests. Another issue is that in communities of color, it's more likely that the healthcare institutions are under-resourced. So they don't have the specialists, they don't have the intensivists, so people who work in the intensive care unit, they may not have as many ventilators or capacity to take care of sick patients with coronavirus. And then job exposure. We know that among essential workers that Black and Latino people are overrepresented for their population in the United States. So they're unable to stay home and work remotely from home, and they're being exposed to the public as well as sick coworkers. And housing and transportation is another issue. So, you know, in New York City, we have very high population density. We have a lot of crowding, as I mentioned, that's having more than one person per room in an apartment or a house. And we know that is a contributing factor to the transmission of the virus. We also do know that in terms of who takes public transportation in major cities, that it is mostly communities of color. So this has also exposed certain populations to the virus. And so what are some strategies that we can use and utilize to really protect communities of color? And so some are targeted testing to the communities that are being impacted the most. We know that contact tracing, which is when you test someone, if they test positive, you actually go out and find everyone that they have had more than 15 minutes of contact with. You find them, you test them. If they test positive, you isolate them. These are basic public health intervention strategies that have been proven to work. They were used in Ebola several years ago, and they should be used now. Also providing hazard pay and personal protective equipment, masks, gowns, and gloves to essential workers to ensure that they are protected. And of course, we talked about those social determinants of health, housing and employment opportunities. We need to really think about all aspects of factors that contribute to a community's health. And one thing that I think is really important is thinking about how state and local public health officials are engaging with communities of color. The messaging and outreach needs to be a little bit different, not even a little bit, a lot different. It needs to be more nuanced. There were certain myths that we heard that were circulating on social media when the pandemic first hit the United States. There were some myths about Black people not being able to contract coronavirus, or the 5G cell phone signal being somehow involved in the coronavirus. And so these are myths that definitely need to be debunked. And that needs to be done in messaging as well as outreach. And then obviously we need to ensure that the healthcare institutions in communities of color are adequately resourced. So there's the whole point of health equity is to ensure that all communities are treated equitably. So if we see communities of color being more heavily impacted, we need to make sure that we're directing resources to those communities. And so obviously going back to the social determinants of health, when this is all said and done with, we need to ensure that these communities have resiliency and have the potential to reach their highest health potential. And so I wanted to share a few things about working on the front lines. I'm in Brooklyn, New York. We are in the epicenter of the pandemic. And I have to say that it was a rough few weeks towards the end of March and in April. This is some pictures of me. I actually had to wear a Band-Aid over my nose because my N95 mask was causing abrasions on my nasal bridge. But I will say that what I saw was very, very scary. I had never seen such sick patients before. Some patients came in and they had oxygen levels of 60%. So most of us that are walking around, our oxygen levels are 100%. So some of the sickest people I've seen in my career, and I've been practicing for over 10 years, some of my colleagues who've been practicing for 35 plus years said the same. They'd never seen anything like this. And so that's why we're, in New York City and in cities where we're seeing spikes in coronavirus, wearing masks, social distancing, all of that is incredibly important to preventing the spread of coronavirus. And because it was such a stressful time, I started meditating again. And, I needed to feel grounded because there was so much uncertainty from day to day. So I meditated, I went on lots of walks, I journaled. I also spent time with my two little ones, one of them who came in a little bit earlier. And so they really helped me to keep my perspective during a very difficult time. So that's some of the content I wanted to share with you. And I'm gonna stop sharing now. I wanted to hear questions from the folks that are listening. Yeah, whenever you're ready.
Amazing. I mean, first of all, just thank you. I mean, the work that you are doing is so meaningful and has so much purpose on so many levels. So it's just remarkable, just as one human to another. Thank you for everything you are doing. That is amazing. I have a couple of questions for you, actually. One of the things I'd like to talk to you about is unconscious bias. I know your organization is doing a lot of training, and we actually this year, as a part of our V2 Mom, or our annual business plan, have that we're going to be running unconscious bias training for everyone. And, we all have them. We all have our blind spots.
Yeah.
And I'm wondering what sort of advice or counsel would you give someone who's kind of just starting on this journey? Because I think so many of us come at this like, oh, well, not me, and certainly as you're, reaching out to doctors and people who are heroes and who have gone into service humans and be better and are high achievers, I'm sure they're coming to your training saying, oh, it's not going to be me.
Absolutely.
Right.
Actually,
So what advice do you
physicians,
have about kind of that approach?
yeah, no, and actually I would say physicians, I've done trainings with a lot of different types of people in different roles, and physicians are literally like, no, I don't have bias. And I'm like, no, because it's unconscious. So that's, it's a little funny, but actually what I tell people at the beginning of my trainings is to really have like a growth mindset, to assume that we don't know everything, right? And we all want to be good people, but the fact is that we're goodish people. We are works in progress. And so I tell them that, you're going to hear some things today that may sound, like you may disagree with them. They may be a little bit uncomfortable, but I ask them to really just come in with that growth mindset. We also have them take the implicit association test, which is available on the Harvard Implicit site, and it's free, available to everybody. And that test is very revealing to a lot of people. I think people are becoming very, very surprised with their results. And I think that is, it causes them to really start thinking a little bit about these biases that they may have, but they don't realize.
That's great. That's a great resource. So we will capture that. We send out an email to our employees every day with different resources, and we'll capture that.
Yeah,
We'll,
definitely. And that website has over 20 tests on it, just different types of bias tests. And so they only take about 5 minutes to take. And so it's a great resource for people to use.
That's great. That's really, really great. Another thing that we talk about a lot here is the importance of a role of an ally. And, maybe you're fortunate enough not to be one of the communities that is experiencing all of this kinds of divides and disparities and inequities. But you have a role to play in fixing it. So, when you showed that like social determinants of health, like if we want to actively get involved and try to help steer this ship, where is our energy best focused?
Right.
Is it in the communities? Is it like, it's COVID-19 time, we should be doing something different? How do we engage?
No, that's such a great question. And I think that right now it's probably going to be with community-based organizations that have been there from day one before all of this, that have been doing advocacy around housing and job and education. Because these are the organizations that already have relationships with the community members, okay? And so that's one way, but other ways are, through voting, through getting involved with, in policy making, or donating to organizations that are doing the work that you support, so housing advocacy groups. And so there are a lot of different ways, and I think that this whole idea of allyship is so important, because really it's the only way that we're going to make any progress, or any way that change is going to happen.
Great. As a technology company, I'm curious to hear from you, because we've talked about the things that need to be done in the communities, and we've talked about, the health institution in and of itself, but as a, health technology is obviously such a huge area. What roles do you think that we have to play in trying to, quell some of this or push some of this off?
No, that's such a great question. And I mentioned this a little bit, but despite the progress that we've seen in health technology, we still have these disparities. And so one thing is obviously community engagement, but another thing, especially with a lot of digital health technology, sort of thinking about how can we target the communities, one that need it most, engaging them to figure out what their needs are. We do know that there is a bandwidth deficit in communities of color. And so we need to make sure that we're getting the resources that everyone needs so that they can use their laptop, that they're not just accessing, apps on their phone. So those are things that we need to start thinking about. And then even with, there are a lot of healthcare algorithms that are being used. And then there was one that was being used by health insurance companies last year. There was an article in Science about this, but the algorithm was predicting how much resources was needed to care for a given patient. And it was calculating that Black patients needed less resources, but that was because patients weren't able to get to their appointments. And so we need to think about these algorithms and how we're using technology, and really to ensure that bias of the software developers, is not being embedded in the software itself.
So, so important. So, so important. Catherine, do we have questions from our employees or from our community?
Yeah. It's another question about allyship. So you talked a little bit about kind of what we can do to help, but do you have any advice or areas where we can go to kind of better educate ourselves about the issues of inequities in healthcare?
Oh, absolutely. So I feel like we're living in a very interesting time, but and I would say social media is really the one of the places to go. So go on Twitter. There are people who like DeRay McKesson, Pod Save America, even I feel like listening to some shows on NPR like the Brian Lehrer show. There are a lot of different people that you can follow, whether it's podcasts or books or on social media, who may have a different perspective than you or experience than you, but you can actually learn a lot from them. And this is something I actually tell people after my unconscious bias trainings, that one part that we know of to mitigating unconscious bias is really exposing yourself to other groups and other experiences and other people. Really, that's the only way.
I love you mentioned Pod Save America. I'm a huge fan, and they have that podcast, America Dissected, that dives into some of the healthcare issues. Uché, did you have another question?
Actually, something that I thought maybe our viewers would be interested in hearing a little bit more about. Can you talk a little bit about redlining?
Yeah, I think it's so important to know. I think when we talk about, racism, people like to think about it as an interpersonal, but really the racism that is most profound and has caused these healthcare disparities is structural racism through different practices and policies. And one of them is redlining. And what redlining was, it was a federal policy in the 1930s that essentially graded neighborhoods from A to D, A being favorable, D being less favorable. And depending on the grade, people were able to get mortgages and mortgage insurances in those neighborhoods. The fact is that the grading was dependent on who was living in those neighborhoods. So mostly Black neighborhoods got low C and D ratings. And so what we know now is that had repercussions for decades. And so what we see now in terms of healthcare disparities, if we were to put a map of the healthcare disparities over the neighborhoods that were redlined, those were the red line areas, because we see that those neighborhoods, that when you buy houses, you invest in a neighborhood, businesses want to come. We know that property taxes go towards education. So what redlining did was basically led to disinvestment in Black neighborhoods, which actually ended up influencing health status.
Mm-hmm. Yeah, it's really quite a web to try and untangle.
Yes. But a lot of this, there's so many great resources online to learn more.
Well, you are an incredible trailblazer, and I really, really want to thank you. I'm quite confident your mom is quite proud of the work that you are doing.
I hope so.
I am proud of you. Yeah. I can only imagine for you. And I just really want to thank you for your time today and all that you are doing. And we will definitely make that resource available from the Harvard website that you told us about. And you just keep trucking on. Just go.
Thanks for having me. Bye, everyone.
So everybody really enjoy yourselves. Take care of yourselves. Be happy. Be well. Take care.